Hello, everybody, and welcome to one of our webinars at Audiometrics. We are today talking about hearing aid verification. You owe it to your patient, and we are very, very proud to be able to introduce with Dr. Gustav Mueller, who is a professor at the Vanderbilt University. I am the moderator. My name is Mariana Rosling Jensen, and I'm education and training manager at Audiometrics. I'm just here to tell you some of the rules of the webinar so you know how it works. So all participants are muted to reduce the background noise. It's possible to ask questions during the session. You have a question box on your right side, so if you write there, I will receive the questions. The questions, I will collect them, and then in the end of the session, I will ask the questions to Professor Gustav Mueller. If you experience any technical problems or you need some support, please send me also a message and I will try to help you through. Gus, thank you for accepting being here today with us. We are really, really proud to have you here. I will hand over the screen so you are able so everybody's able to see your presentation. Good. Welcome once more, Gus.
Well, thank you for for inviting me. This promises to be a fun time. I know there are people out there coming from all parts of the world. To go into a little bit more detail here of what I do, and I'm not doing webinars. I do have faculty appointments at Vanderbilt, but also at Rush University and Northern Colorado. In the spirit of full disclosure, I'm a consultant for the Cervantes Group, and I'm also the contributing editor for Audiology Online. I'm coming to you today from North Dakota. I know people are listening from all over the world, and for me, it's 8 in the morning. I'm on my second cup of coffee. I'm a little jealous because for some of you, it's probably happy hour, and I have to wait 9 hours for that. Anyway, North Dakota, for those of you who don't know, is the second coldest state to Alaska in the U.S. And I live on the largest island in North Dakota, and this is what it looks like most of the year is something like this. However, we do have 2 months of summer, and this is one of those months. And so this is the Missouri River, which is basically my backyard. So this is for 2 months of the year I get to have this this view looking off my back deck when I'm not traveling somewhere. As this course was advertised, this is a course to discuss why you would want to use probe mic measures. So that would tell me that most of you who are tuning in are on the fence of whether you believe it's something that should be done or should not be done. And that's what this is all about, is why I believe it's something that is critical for all of you when you fit hearing aids. Now, if by chance you just tuned in because you're curious and you're already doing probe mic measures, here's a couple courses for you. These are courses that I have recorded. They're free at Audiology Online. The first one I have listed here is a 2-hour course that just goes through all the nuts and bolts of positioning the patient and how to place the probe tube and what all the different tests are for somebody who's just getting started. For you seasoned veterans, here is a second course. This is a course that I went through several puzzling outcomes that I had obtained in seeing patients and tried to come up with what I thought was my best answer for what might be happening relative to probe mic measures. So these are courses at Audiology Online. If you're taking them for CEUs, then indeed you have to pay money. But if you just want to go in and take the course, there's no charge. Those are certainly available. And of course, I do have this handy little book that fits very nicely under your pillow. I need to mention that this was supported by a grant from Odometrics, our sponsors today. Colleagues Ruth Bentler, Todd Ricketts, and I put this together, and that's available from Plural Publishing. Well, let's start with one of the most important distinctions, and that distinction is that probe mic measures are not a method of fitting hearing aids. I sometimes hear people talking and they say, well, do you use probe? No, I don't use probe. Gee, I don't know if probe really works. That's a big misconception of what probe mic measures are about. They're not a way to fit hearing aids. They're a way to verify your method of fitting hearing aids. So what does that mean? That means that you have to have a method, and hopefully you all do. So how are you going to come up with your method? How are you going to decide what output at the eardrum is going to satisfy the 5 things that I have listed here? Things you might want to consider would be maximizing speech understanding. That's what most patients want. What about audibility? It says here maximize audibility. That's not always a good thing. You really have to optimize audibility. Do you want to maximize listening comfort? Well, yes, you want something that sounds good, which leads us to sound quality, but also you need something that the patient's willing to wear. Certainly during those first few weeks for a new hearing aid user. So somehow you need to take all these things, you need to throw them in a pot, you need to stir them up, and you need to come out with what is the best for the average person walking into your clinic. Well, I have some good news for you. Other people have done the work for us. They've done all the heavy lifting. There are 2 well-established fitting methods today. One of them, the DSL, has been around since 1984. What you see here is a photo of Richard Seawald, who is the original DSL guru. That now has been turned over to Susan Scully in the last 5 years. This is from the University of Western Ontario. The original NAL was from Dennis Byrne, which was then taken over by Harvey Dillon. And I'm not really sure now that Harvey's mostly retired. I'm not entirely sure who's in charge of the NAL right now. But the NAL has been around since 1976, and it just keeps getting better with every version. So we have these 2 methods. These people have done all the heavy lifting, which is great because it makes our job a lot easier. All we really have to do is pick one of these 2 methods and run with it. So the question I guess you could have is, well, which one do I pick? Well, let's take a look and see if it really matters. So let's look at the methods we have right now, which would be the DSL version 5 versus the NAL NL2. A few years back, actually I think it was maybe in 2011 or so, maybe 2012, Earl Johnson and Harvey published an article in JAAA, which compared these methods. I have a monthly column at Audiology Online called 20Q, and Earl wrote a brief review of that article for me. So this is sort of the condensed version, but if you want all the details, go to the JAAA article. What these individuals did was to audiometrically come up with 5 different audiograms and then look to see what would be the prescribed gain for the 2 different methods so that they could make a comparison. These are the audiograms that they used, and you can see that there's one that's upward sloping, one that's flat. So we have 5 different audiograms here. Now this compares gain called for by the NL2 versus the DSL version 5. So if the line is above 0, that means that DSL is calling for more gain. If it's below the line, that means that the nail is. Now, at first glance, you're going, whoa, there's some pretty big differences here. But let's take it down to the way we're normally thinking in the clinic, and that's we're usually concerned about gain between 500 and 4,000 hertz. And usually, if we're within a plus or minus 5 region, we're okay. We don't get too excited about small differences when we're doing these fittings. So what you see here, if you look at plus or minus 5, for the most part, these two methods are very similar. Yes, indeed, for 2 audiograms, there was a little more gain for the nail, but for the most part, for the 5 different audiograms, you will get very similar fittings. Now, this, of course, is the DSL for adults and the NAL for adults. If we look at children, the differences might be a little greater, but my talk today is really just focused on adults. Again, this is from the Johnson and Dillon article. What we have here are the SIIs for those 5 different audiograms. The only one where there's really a difference at all is the audiogram 2. I marked on there that this was the upward sloping hearing loss to remind myself of that. And what you see there, you do get an SII that's probably significantly bigger for the DSL. But if you average all these audiograms together and look down on the bottom right where the blue arrows are, what you see that the average for all of these for the DSL is 0.70, for the NL2 is 0.69. That's about as close as you can get. So what we have then is that it probably isn't worth a lot of your time to decide, do I pick the DSL or do I pick the NAL when you're fitting adults? Basically, just pick one of the two. Around the world, the NAL is probably the most popular with adults, the DSL with children, but you certainly could flip-flop those to your liking. So now you have your blueprint. You have your gold standard, and that is you have targets to fit through. Well, I think. Well, let's think this through and see how you would make the decision yourself. The way I see it is probe mic measures are all about verification. So you start with asking yourself the question, what am I going to verify? And you really have 3 choices. You could make something up yourself. So that would be one choice. And I hear people say that. They say, you know what, I don't use that nail fitting. I got a better way to fit hearing aids. And my response is always the same. Well, then publish it if it's better. If it's really better, you should be able to write it down and publish it. Well, here's another choice. You could try something that a hearing aid manufacturer made up. You would believe that some manufacturer knows best how hearing aids should be fitted, and you could pick that approach. Or there's another approach, and that is you could pick something that's been validated with 30 to 40 years of research. To me, this isn't really a tough decision. I'm going with this one over here. So what next? Now you have what your gold standard is. What's your next step? How can you ensure that your fitting goals are being met? Well, again, I think you have 3 choices. You can click on the manufacturer's magic button that says NL2 and just hope you get lucky. You won't, by the way. We'll talk about that later. You could ask the patient. You could say, you know, Bob, could you tell me, are you getting about 92 dB SPL at your ear canal at 4K? You know, maybe Bob knows. Most Bobs don't. Or you could do this radical thing, is you could actually measure it. And you could see if indeed you are obtaining your prescriptive fit. Again, I don't think this is really tough logic. I think this is the answer. So then the question becomes, is there a plan B? Is there another way to fit hearing aids? I struggle to think of what it possibly could be. Now, the fact that you tuned in today tells me that you all must have the question, Is there proof that Plan A works? So let's talk about that. By Plan A, what I mean is that we have audiometric thresholds, and using one of these prescriptive methods, this happens to be the now right here, we derive fitting targets. We then deliver a real speech signal, such as the ISTS. We look at the gain and output in the real ear, and our goal is to, as close as possible, match those prescriptive targets, with the belief that this will optimize all 5 of those factors that I mentioned for the average patient. So for those of you who don't believe in this, and unfortunately there are a lot of people who don't believe in this, what is the plan B of these people? My best guess, actually it's not only a guess, it's what is happening. The majority use the proprietary default fitting of their favorite manufacturer. So let's have some competition. Most of you like sports, so let's have a little competition here. You're looking at a verified prescriptive fitting versus the default fitting of your favorite manufacturer. Who's going to win? Let's look a little bit at the real ear output. Here's a study that we did 3 years ago, and where we looked at the real ear output for proprietary fittings and with the premier hearing aids of leading manufacturers, and compared it to the now. So we selected the default fitting from all the different manufacturers. We entered all the appropriate data for the type of hearing loss, the type of plumbing that we used, and so on. And we matched this characteristics to our probe mic equipment. And then we simply conducted probe mic measures using speech mapping. And we did this on 16 different ears. So what you'll see here then is from these 5 different leading manufacturers. So here's what we get for a 50 dB SPL input. Now I put the now on there, that's the red, just so you had a comparison point. So what you see there is the 5 different manufacturers, what you get for the proprietary fit versus what you'd get if you fitted to the now. And to no one's surprise, all of the proprietary fits roll off gain in the highs, usually starting about 2K, but notice some of them are even about 10 dB below at 2K. One of them on here, I wish I would have demonstrated this, but Mr. Purple on this chart is essentially no different than the patient's real ear unaided response. In other words, taking the hearing aid out of their ear, they would have had essentially the same gain from their natural ear canal resonance as they were getting from the proprietary fitting. This is for soft inputs. Now, what happens if we go up to average? Well, now you notice the proprietary starts to go above the now, although still below in the high frequencies. And let's go up to 75. And now you see the proprietary are all overshooting the now. Finally, they have enough gain in the highs, but at 2K, they're well over the now as much as 10 dB. If we look at SIIs, this shouldn't surprise you. Over on the far right, I have the SII you'd be getting with the now. What you see here, if you look at all the pink bars, notice how far many of these are below the now. For average, which is the white, we're a little closer. And now for loud, because they overshoot in the mid frequencies, the SIIs for the loud are actually fairly similar. But there's a problem. So let's just go back. A lot of research with the now has been conducted relative to what is the best loudness for a given frequency. Look at the now target at 2K, which is an 80 dB SPL output. Mr. Green on here is 10 dB above. If this person has a VC, I would bet anything they're not going to be using their hearing aids at that loudness level. They're going to turn it down about 10 dB, which means that the soft inputs are going to be even worse than they already are, because you can't turn down loud without also turning down soft. Well, you can as an audiologist, but the patient can't. Those loud SIIs are a little misleading because I don't think you'd see that SII in a use condition. Speaking of SIIs and speech understanding, most of you know this handy chart where we can actually take an SII and predict what it would be for speech understanding. So let's go back and say a couple of those hearing aids for soft had an SII of about 30%, which you would predict would be 60% on speech understanding. If we go up to what you would get with the nail, 97%. 60% versus 97%. Would a patient ever notice that? I think so. Would an audiologist ever send somebody out the door with 60% when they could have given them 95%? It happens every day. It's happening right now somewhere. Guarantee it. Well, here's one of my favorite studies by Ron Leavitt and Carol Flexer, conducted a few years ago. What they did again is they took the top 6 hearing aids and they programmed them to the manufacturer's recommended default fitting. And just for the fun of it, for benchmarking purposes, they took an old pair of hearing aids, single channel analog from 2002, which they programmed to the now. All experienced hearing aid users, they were fitted bilaterally, and they were tested with the quick SIN. So the scores that you're going to see in a minute are in SNR loss. And this was all presented right about an average speech. Average speech is 58 to 60, and they presented it at 57. So we're maybe just a hair below average speech, but pretty much at average, in between average and soft speech. So here's what they had. So what you're seeing over there on the far right, now this is SNR loss. So on average, fitted with the old hearing aid to the now, these individuals had an 8 dB SNR loss, meaning that they needed an SNR 8 dB better than somebody with normal hearing to understand at the 50% point of the quicksand test. Well, what happened when we took these new Premier hearing aids with directional and noise reduction? What were their quicksand scores? Hearing aid 1, hearing aid 2, hearing aid 3. Did I tell you that down is bad? Hearing aid 4, hearing aid 5, and hearing aid 6. So what you see here, if this patient had walked in wearing hearing aids that were over 10 years old, but programmed to the now, and was fitted by an audiologist to a brand new set of hearing aids fitted to the manufacturer's proprietary fitting, they would have been much better off to keep their old hearing aids. Notice that in hearing aid 3 and 4, using their new hearing aids, they needed an SNR of 8 dB better to perform as well as they were performing with the old hearing aids. Wow. Why would anybody do that to a patient? You got to ask. Well, what happened if somebody would have been so cavalier as to program these hearing aids to the now? Well, they did that in this study. Hearing aid 1, hearing aid 2, hearing aid 3, hearing aid 4, hearing aid 5. Hearing aid 5 still has problems, and hearing aid 6. So except for hearing aid 5, what you see here is when you program the hearing aids correctly, now you're getting a 3-4 dB advantage over the old hearing aids, which is exactly what you'd expect with new technology. This points up something, and also notice that for the most part, there isn't a lot of difference between the different hearing aids. We're looking at 1 or 2 dB, really. It tells the story very well. It's not so much the product that you get, it's who's doing the programming. Notice, for example, that hearing aids 3 and 4 improved by almost 10 dB in SNR, just depending on how they were programmed. This is why the world needs us. Us meaning people who know how to program hearing aids. But you know what? If we don't do our job, then people might as well go get their hearing aids at a department store or at a Walmart or the neighborhood pharmacy, because the kiosk there can do first fit for them, and they'll have what you see on this chart. Well, here's another study. I don't have time to go into all the details, but again, it compared the NAL to the proprietary fit. I wanted to include this because it had some real world aspect to it. This is using the APHAB. What you see down in the bottom is listening and quiet, listening and reverberation, and background noise. And in all three cases, there's significant benefit for the prescriptive fitting. So the now prescriptive fitting in this case. So again, it's not just a laboratory thing. It happens in the real world. Which takes us to the most recent study on this topic. This is from just last year by Mike Valente and colleagues. Was a crossover design study, meaning all people had both the prescriptive fit and the proprietary fit at one time or another in the study. And Mike did a lot of testing with this in quiet and in noise, and also then had real world comparisons. Again, I don't have time to go through all of this, but let me give you a few high points. First, what Mike published, and which should be to the surprise of no one, is he compared the proprietary fitting to what people would have had with the NAL. Now, this is a little hard to see, so I put some red lines on here. What these X's, if the X's were on the red lines, then the proprietary fitting would be the same as the NAL. As you can see, they are not. They fall below. And for soft, the average error is 14 dB. I don't know if you can see this, but look at 4K. On average, the proprietary fitting is 20 dB below the NAL. 20 dB below the NAL. Yes, indeed, that helps eliminate feedback. But you know, taking the battery out eliminates feedback too. Why don't you just fit a product with a good feedback reduction system and fit to the NAL? That would be my solution. Well, let's go over to average. You see it's 8 dB below and on average. And again, for loud, not so much. And this is because these proprietary fittings are basically linear fittings. That's why you see that they tend to be pretty good for loud and pretty rotten for soft. Well, given those findings, you could almost predict what the results are going to be, right? So what he found in the laboratory, significantly reduced speech recognition for the NAL. In the real world, let's see, there were two different self-assessment scales. The APHAB, I know, was statistically significant, which I'll show you in a moment, in favor of the NL2. I don't know if the other one was significantly beneficial or not, but we're going to talk about the APHAB in a second. He also, at the end, remember this was a crossover trial, he asked people what they wanted to continue to use. 19 of the 24 preferred the NAL. Just a little bit more on the speech testing. This is at above average speech. So the higher your speech input, the more forgiving it's going to be for the proprietary fit, because the patient doesn't need as much gain. Not to mention that they're going to get some leakage around their ear tips, because they're sitting. It's a sound field test. So what you see here, though, it's still significant, where the NL2 is superior to the proprietary fitting at this input. But look what happens when we go to soft. What you're looking at in here are box plots. So that box is the 25th to the 75th percentile. So what you notice that with the NAL fitting, the 75th percentile is better than the 25th percentile for the proprietary. And notice that at least one person in the proprietary is all the way down to 20%, where the worst in the NAL, and may be the same person, is around 65%. A huge difference for listening to soft speech. Exactly what we predicted from those SII findings that I showed you earlier. But you know, somewhere, someplace today, I'll bet you anything, there's a rep telling a naive audiologist, trust me, our hearing aids work the best when you use our proprietary fitting. I bet you it's happening today. here are those APHAB results I talked about. Two teaching points here. One, what you see is a significant benefit for the NL to fit. And what I added to Mike's slides is some of Robin Cox's data, which showed that APHAB scores for older people with normal hearing, and that's the far right bar. So what you see here is not only is the NAL fit better than the default fit, but with the NAL fit in the real world, based on the APHAB, which is the patient's report, people fitted to the NAL are doing as well as people with normal hearing. Not bad. Well, who won this competition? Any ideas? I don't think it was even close. In fact, I would go so far to say that you would be professionally negligent to fit your patients to a proprietary prescriptive algorithms. Why send them out with something that research clearly has shown is not going to work very well? Catherine Palmer wrote an article about this in Audiology today. Those of you who are instructors out there, this is great reading for your students, pointing out that it actually is unethical to charge money for something and not fit the hearing aid as good as you possibly could. You're not really providing the best possible services, which is part of the ethical code of all audiology organizations that I know of. How many people in the US are suffering from being fitted incorrectly? Well, I can't tell you about the US, but I can tell you about what's happening out in Oregon. And I can tell you that because of this research that was published by Ron Lemon, Ruth Bentler, and Carol Flexer. They looked at 97 patients, 176 fittings, which came from a variety of clinics that all happened to be tested at this one major center where Ron Leavitt is working. These are people who were not fitted by that center, but who came to them from other places, mostly for rehab classes. What they found, the mismatch from NAL target of 10 dB or more, 72%. Mismatch a target by 5 dB or more, 98%. The fitting error was pretty much the same for newer versus older. It was a little smaller for 5 of the big 6 companies compared to the other 11 brands. Some of you out there might find that interesting, that the fitting error was no different whether the hearing aid had been fitted by an audiologist versus a hearing instrument specialist. That shouldn't really surprise anybody, because if all you do is click on a tab, it doesn't really matter who clicks on the tab, whether it's an audiologist, a hearing aid specialist, a 10-year-old, the doctor's nurse, your pet poodle, you're going to get the same fit no matter who pushes a button. So I've been talking a lot about why I think prescriptive methods are good and why I think that it's the way to go. But there's one other point here that I need to make, and that is fitting by a prescriptive method is ear canal SPL. I did a survey years ago, 10 years ago about it was, where we found that in that survey, 82%, I believe it was, people said they use a prescriptive fitting. And when we looked at that 82%, only 45% of them were using probe mic measures. Now, hopefully that seems a little bizarre to you, because it is. And that's why I'm using this example. Imagine somebody telling you that they drove exactly 80 kilometers an hour for the past 10 minutes. And when you asked them if they kept their eyes glued to the speedometer, they told you that their speedometer didn't work. You would find that to be a bit bizarre, I would hope, but it is no more bizarre than thinking you're fitting to a prescriptive fitting and not verifying it. And let me tell you why. We got another competition, and that is a verified prescriptive fitting versus clicking on that magic button. What is the probability of you really getting a now fit when you hit now? Well, here's a study back from about 10 years ago. They found that only 30% of the fittings were within 10 dB. when you clicked on the now. Here's another study from by that same research group. They found actually things got worse. Only 29% were within 10 dB when they repeated the study. Now, this second study was only done with one manufacturer. Maybe things have gotten better. So when we did this, the study that I mentioned earlier with the proprietary fitting, this study right here, we also looked to see what happened if you clicked on NL2. So this is now data collected in 2014. So it's 4 years old, and you might say, oh, I bet things are better. I just did a probe mic workshop 2 weeks ago, and from what I could, we had 3 different manufacturers of probe mic equipment and 4 different manufacturers from hearing aids. I don't think things are any better. So let me tell you what we did. We did the same thing as before, except this time instead of clicking on proprietary, we clicked on NL2, and we matched everything up to make sure it was an experienced user, same type of ear molds, and then we set all this in the probe mic equipment. Now, if we had a perfect match to the now, all the lines would be straight across around 0. I mean, we wouldn't expect perfect. We'd want, we'd expect maybe plus or minus 3 dB of error just because of different RECDs perhaps, but it's not even close. And let me tell you, in all cases, on the fitting screen, there was never more than a 1 or 2 dB error. In fact, most of the time, there was no error not. It was a perfect match on the fitting screen. So if all you had done is looked at the fitting screen, you'd be patting yourself on the back and saying, I'm a great person, I fitted to the now. When in fact, take a look at this. With some of those hearing aids, you're actually misfitting by 12 to 14 dB, even though the cartoon on the screen says that it's a good fit. The only product that came close was Mr. Red in this particular case, which on average is only off by about 3 dB. Not bad. We go up to 65, and did things get better? Well, a little, but we're still off by 8 to 10 dB in the highs. And we go up to loud, and now we're getting too much gain in the lows, and we're still actually down a little bit in the highs. Looking by the numbers, 74% of the 80 fittings were 10 dB or more from the now. If we eliminate that one product that was okay, it jumps all the way up to 86% and these are all premier hearing aids. This is top of the line from the big 6 companies. So the now is only the now if you verify it and adjust until you fit to the now. This one, when you thought you were fitting to the now, you had an SII of 0.28 for Mr. Purple. And you see how that is. 50 versus 95%. Who would do that to one of their patients, you wonder? Things just don't seem right in the world. Which takes us back to this. This is also simple, folks. You start with a validated prescriptive method and you verify it in the real ear. That's what we do. That's what makes us professionals. That's what separates us from the rest of the pack. Well, I actually have some more good news, and that is doing the ethical thing actually gives some added bonuses. So let's talk about that, and this will finish us up. This is a real fun study, I thought, to read anyway, by Amlani and Pumford and Gessling. So here's what they asked. Does the simple act of conducting probe mic verification improve the patient's perception? So what they did is they took, they had a total of 60 people, and they had 20 in each group. One was experienced hearing aid users. Another were owners of hearing aids, but not really regular users. And the third was people who had never used hearing aids. And they followed the same group, same protocol for everybody. They spent the same amount of time with everybody. 1/2 of them obtained probe mic measures. The other half did not, okay? Which is the other half is just called quick fit, meaning they push the magic button. And they had 2 different post-fitting questionnaires. One of them is something called willingness to pay. This is something that's done very commonly in in medical research to get that patient's value of something, and they anchored that at 250, meaning they told the patients up front, this typically, what we just did with you typically costs around $250, and then the patient ranked what they thought it was worth. They could have left it open-ended. There's two different ways to do that. And then they had a scale, which I won't go into the detail, but it simply measured the attitude and behavior in different dimensions relative to the product and the provider. Here's the results for the three different groups. And I'm just going to, I'll talk about the experienced users, but you can see it's the same pattern for all the groups. But I want to go into the detail here so you see what we have. This is now the willingness to pay. So remember, the experienced users had already been fitted somewhere else. So they were first asked to give the value of their previous fitting, which you see was at about $100. Then this is the half of them who gave the value of the fitting for what they're calling quick fit. So that's no probe mic, and that's about $130. The people who received probe mic were up at about $330. And then they took the people from that other group and they brought them back because they couldn't let them walking around fit to proprietary fitting because these are ethical individuals. So they brought them back and refitted them and asked them what they thought, and they were right the same as the others. They now, when previously they thought the fitting was worth $130, they now thought the fitting was worth around $350. Simply by doing probe mic. Look at this. This is, again, they asked, the service I obtained was outstanding. They're ranking value. Not sure why the numbers aren't 6s and 7s, but forget about that for a moment and look at relative values. If they didn't have probe mic, there was not a lot of value assigned. And here's an important one. The service I obtained improved my perception of the product. Notice particularly in the middle group, who previously had not been using their hearing aids, now are seeing a much greater value in their product. And as you all know, when you fit hearing aids, if the patient sees value in the product, if they believe in it, there's a much greater chance that they're going to use the hearing aids. So these are all bonus reasons for doing probe mic verification. So to summarize, fitting to validated TARDIS, what does it get us? We know it gets us better speech recognition for the patient, both in quiet and in background noise. It gets us better patient satisfaction, better patient loyalty, better patient perspective of the product and our services, and hopefully a greater sense of professionalism for the audiologist who's doing the testing. I've been talking about probe mic measures since 1983. Have worked with a lot of students at many universities, a lot of workshops. And what I hear all the time is a student will tell me, you know, Dr. Mueller, I'm really embarrassed to tell you this, but I went out and started work at this clinic and nobody there does probe mic measures, so I don't do them anymore either. So I like this quote from my buddy Leo, who says, wrong does not cease to be wrong because the majority share in it. You know, we're professionals. You got to take your beliefs. You have to go home at night and look yourself in the mirror and say, yes, I'm a good person. I'm an ethical person. I'm a moral person. It doesn't matter what the person next to you is doing. I think it's, you know, if we can't do the right thing, our profession is in trouble. So hopefully I've convinced a few of you who are sitting on the fence to become verification believers. It's a great clubhouse that we're in. We have a lot of fun in the clubhouse, and we also believe our patients are thanking us for it. So thank you for your attention wherever you may be in the world. And I'm ready to take questions.
Hi, Gus. Thank you very much for your presentations. I think it fits really well where we are right now in many countries where we have to question the presence of audiologists. What is the difference between audiologists and the other people fitting hearing aids? I think you pointed that really well. Thank you for that. I hope nobody else has a question of why they should verify. their feeding anymore, because I think it was pretty clear why we should do that. I have to ask if there is any questions. I haven't received anything. Oh, there is one now. Let me see if I can read. I would like to ask, when do we do PMM for rig products that needs vent of 2 millimeters? Do you get different results for vent and dome and vent and custom modes?
Would I get different results? The answer is no, because I'm going to be fitting to a prescriptive target. So yes, indeed, if you have venting, depending on the degree of venting, you will have leakage in the low frequencies. So you may have to apply more gain. But if my prescriptive target for 500 hertz is an output of 72 dB SPL in the ear canal, what is leaking out doesn't really matter, because I'm going to compensate for that by what I program into the hearing aid. So it's an indirect effect, but it doesn't affect your final goal is to attempt to achieve your fitting target. How you get there doesn't really matter that much. If that indeed was the question. But yes, the degree, the more venting you have, the more low frequencies you'll be losing.
Yes. Thanks.
I'm not sure that's
you answered the question. I think you answered the question. I will take another one, a last one. I've not found that PMM verification of hertz compression shows anything different. I've used UVO Ling, and ISTS. Do you have any thoughts on that?
Well, I'm not sure what you mean by showing any difference. So let me give you an answer that may not be the question, but it's an important thing to keep in mind. Some of us, back when we were getting our training in audiology, we learned about compression, and that is, if you take a signal and you compress it by 2 to 1, you only have half what you had before. When you're using real speech, it doesn't work that way. So if I were to take a 30 dB, real speech input signal, which is usually what you're delivering, if say you're using the ISTS, the input will be about 30 dB, and I'm using compression of 2 to 1, the output is not going to be 15 dB. If that's what the question is.
I think
that's
the question is more like
real speech, and it's something called effective compression. So if you have 2 to 1, your effective compression might be more like 1.3 to 1 or something like that. You don't have the squash effect that you would when you're looking at pure tones. Now, this is dependent, however, on the release time that you're using with your products, which is why some products give you the option of using different release times. The faster your release time is, let's say you're using a release time of 50 milliseconds, you'll get much more of a squash effect with your compression, which will make it easier to match your targets, I might add, because if you look at your NAL targets, for example, it's not uncommon that in between 55 and 75 dB, the targets are only separated by 10 dB, which means that you're going to have to be reducing the speech for the 75 dB input if you start off by matching your soft. So the faster release time you use, I would encourage you, for the person who asked the question, you can play around with this a little bit. Go in and deliver a signal, use something like 65 dB so you're up above the knee point, and turn compression, go to 1 to 1 and run a curve, and then go to 3 to 1 and run a curve. My bet is if you have a slow release, you'll probably see a reduction in the overall output of about 10 dB, but you won't see like 3 to 1 compression. Now, the other thing you can do, if you have a product that allows you to change release time, is go back to that 3 to 1, try it with a slow release time, which is the default for almost all products today, and then set it to a fast release time. And my bet is that you'll see more compression effects.
I think the question was more related to frequency compression and the test,
okay.
and if you can, he's not seeing difference in SII values when he's using frequency compression.
Okay, well, so I answered it, but I like my answer to the question that wasn't asked.
I like to. Okay. I like to. That's why I didn't interrupt you.
Okay, frequency compression. Okay, so now let me think. So first of all, as hopefully all you know out there, if you want to see the effects of frequency compression, you're going to have to use specialized signals. These are not, you can't use, by the way, the Lang signals because they were really geared for testing hearing. You need to use these specialized signals developed at University of Western Ontario that are the extracted from the ISTS. And those signals, I'm going to say, are available on the odometrics equipment. I'm quite certain of that. So let's assume that you're using these signals and you're now determining if you have made the S and the SH audible. The question then becomes, does that change your SII? I didn't even know that they were doing SII calculations on that when you use those specialized signals. Now, if you weren't using the specialized signals and you were using the ISTS, you wouldn't expect to see a change in your SII because the lowered signal is lumped right into the signal at that particular frequency, and you're not going to see any difference. That's why you have to use the specialized signal to look at frequency lowering. You can't, all the ISTS is going to tell you is that you turned it on, because you're going to see something's gone out there in the highs, but you aren't going to know where it went to because it's going to be blended in with all the with the input at the given frequency where it was lowered to. Maybe that was a better answer to the question than the first one.
Okay, thank you.
That was a terrible answer.
Look, he is still asking, but I will have to stop because we are over time, and I will actually recommend the person who asked this question. We have actually another webinar, I think it was 2 months ago, and you can still go in and watch how to fit with frequency compression. Was Wendy did a pretty good job showing exactly how you should apply the frequency compression and use verification to verify if you're achieving what you need. So I will recommend you to go into our website and look at this webinar that we have there recorded. I think we have to end it now. I can see that we are a little bit over time, or a lot over time. I really want to say thanks for you guys to participate in this. It was a really, really good webinar. I'm very satisfied, and I hope people out there are also enjoying to hear you. Thank you very much.
Good, everybody, and enjoy your day. And if you have a burning question, don't hesitate to contact me. My email was on that initial sheet. You know, I'm just a lonely guy sitting in a cold state in North Dakota, and would be happy to be your pen pal regarding probe mic measures. So thanks for your attention.
Thank you very much. Thank you, everybody, for participating.